Good evening, everyone. On behalf of IACM, I extend a warm welcome to all of you. You will be happy to know that today is the 7th of our national online CMEs. The topic this time is diabetes. For members who are joining us for the first time, I'd like to inform them that these CMEs are being held regularly on the first Thursday of every month from 8 to 9:30 p.m. I'm happy to share with you all that today we are blessed by the presence of legends of clinical medicine in India who have very graciously accepted to be a part of our deliberations in the form of guests of honor, chairpersons, moderators, and speakers. I welcome you all on behalf of IACM. The guests of honor for today's program are Dr. K.K. Parikh sir and Dr. S.K. Sharma sir. Dr. K.K. Parikh sir is a personality which needs no introduction at any forum. He's been past president of API, past dean, Indian College of Physicians, but most importantly for us, he's the current president of IACM. It was his idea to have these CMEs as he wanted that the experience and expertise of the master teacher is made available even to the remotest clinician of our association. He is the heart and soul behind these CMEs. He has worked tirelessly from day one in all these 7 CMEs. With these words, I'll request Dr. K.K. Parikh sir to say a few words to our delegates.
Thank you, Dr. MP. Good evening, friends. सबसे पहले तो मैं आप सबको जन्माष्टमी की और भगवान कृष्ण के जन्म की बहुत-बहुत शुभकामनाएं. आज इतना शुभ दिन है एंड हम सीएमई करने जा रहे हैं और इतने इम्पोर्टेंट टॉपिक पे डायबिटीज पे. So it's really a pleasure and an honor for me to welcome all of you, especially our guest of honor, Dr. S.K. Sharma, who is the first endocrinologist of Rajasthan state and one of the most senior endocrinologists and an excellent orator, a good human being, and his passion is to disseminate knowledge to everyone. Even in the COVID time, he was having CME programs once in every week, and to everyone at the remote places. I mean, he is the role model for dissemination of knowledge to the clinicians. So thank you very much, Dr. S.K. Sharma, to be here to grace this occasion. I welcome you. Our chairpersons, my friend and younger brother, Dr. Pradyuman Sharma, who is chairman of Jaipur API, and a very good orator, very good friend, wonderful clinician, and a chest physician of great repute. He has got his own hospital, Gopinath Hospital, and he is also the man who also involved in dissemination of knowledge on our scientific committee society. So thank you very much, Dr. Pradyuman Sharma. Dr. Puneet Saxena, professor of medicine and the man who very successfully organized Epicon 2022 at Jaipur. You all know that at the COVID time, we could do it in Jaipur, and it was his dedicated hard work so that we could successfully organize the CME, this Epicon 2021. Thank you, Dr. Puneet Saxena.
Thank you, sir.
Thank you. Dr. Arvind Gupta, past chairman of Rajasthan SSDI, a great researcher, wonderful orator, and a very good human being. Dr. Arvind Gupta has got so many publications at a national and international journal. He is a very good orator and a thorough gentleman. So I welcome Dr. Arvind Gupta.
Yes, thank you.
We have got 2 legends of medical fraternity, Dr. Shashank Joshi, who does not need any introduction at this forum, but he is academician of great repute, not in India, but internationally also. He is an excellent orator, a good human being, and a friend of friends. I requested him at a very short period, but he was ready to speak at any time. And he today is here to grace this occasion to give us knowledge about insulin and how to use it, how to reduce the doses, how to increase the doses, and what is, type 1, type 2, everything. So he will be joining us later on. Thank you very much, Dr. Shashank Joshi, to be here as a speaker and to grace this occasion. Dr. Virmani is a great orator. He is a great academician, researcher, and a great clinician. Thank you very much, Dr. Virmani, to be here to as a speaker to grace this occasion. At the last but not the least, Dr. MP Singh. He is the man behind all these shows, very dedicated and hard work he is doing to organize these CME and to disseminate the knowledge to all of us and the clinicians, every part of India. We are having, as he said, we are having on every first Thursday of every month these online CME, and I think we are getting a lot of knowledge and updating ourselves on different subjects because of these CMEs. I think these CMEs are also very, very important other than the physical CME programs, because we can do it them every frequently, and there is no need to travel so far for everyone. So these CMEs are really great academic knowledge, spreading academic knowledge to all of us. Thank you everyone for being here, and I also welcome and extend my sincere thanks to all delegates who are attending today's CME programs and making it a great success. Thank you very much. Jai Hind, Jai IACM, Jai Bharat. So, yes, Dr. MP.
Thank you, sir, for your inspiring words. It's an honor to be a part of your team. Dr. S.K. Sharma, sir, is our second guest of honor. Sir is Professor of Endocrinology at Mahatma Gandhi Medical College, Jaipur. Sir did his DM in Endocrinology from PGI Chandigarh. He is the current chairperson of Diabetes Welfare Society. He has numerous research papers to his credit. He's been awarded with numerous orations, including the RSSDI oration of 2016. Sir was the organizing chairperson of the recently concluded and the very successful inaugural conference of Rajasthan chapter of IACM, which we all attended. We welcome you, sir, and I invite you to say a few words to us, sir.
Thank you, sir. Thank you, Dr. MP Singh ji. And my namaskar to all the stalwarts who are present here, and good evening to all the friends on this very auspicious occasion of Janmashtami. I welcome you all here. And today we are going to discuss a very important subject and a very practical approach how to manage type 2 diabetes in our patient, either by oral drugs by Dr. Virmani and by insulin by Dr. Shashank Joshi. Dear friends, we all know diabetes is having a huge burden in India. We are having large number of diabetic patients and pre-diabetic patients also. Diabetic patients are having heterogeneous appearance or presentation. They may be coming to us at a very young age or old age. They may be overweight or thin. They may be having short duration of diabetes, long duration of diabetes. Some are coming with, you can say, without any comorbidities. Others are coming with significant comorbidities. So luckily, we have so many drugs now available to target all these aspects of different, you can say, profile of our diabetic patients. So you can say patients centric approach will be now available, and we all know that ADA-ASD you can say guidelines are telling us that according to the characteristics of the patient, we have to select the doses and drugs. And we all know that the burden of cardiovascular disease and nephropathy are increasing in a lot of our patients. So selecting drugs which target these complications are also very, very important. Or of course, we have patients who need different types of drugs. Diabetes is a progressive disease. It is an era of combination of drugs. So Dr. Virmani will be telling us how to smartly combine different drugs with different mechanisms of actions so that we can achieve good control without side effects of these drugs, and we will have good prevention of complications of diabetes. With this, I will hand over to Dr. MPC. Thank you, sir.
Thank you, sir, for your kind words. It's an honor to have you with us. We welcome you once again. The chairpersons for today's meeting are Dr. Pradyuman Sharma, sir, and Dr. Puneet Saxena, sir. Dr. Pradyuman Sharma, sir, as Dr. Parekh told, is one of the senior most physicians of Rajasthan. He is a very senior consultant physician and expertise of more than 4 decades in management of diabetes, diabetic foot, allergy, asthma, and immunology. He is a fellow of numerous associations, including ICP, IACM, and RSSDI. We are honored to have you with us, sir. The second chairperson for today's meeting is Dr. Puneet Saxena, sir. Sir is a senior professor of medicine in Medical College, Jaipur. He has been member of governing body of API, organizing secretary of Epicon 22 held in Jaipur, which is one of the most successful Epicon held till date. He is the vice chairman of the Rajasthan chapter of RSSDI. He has been taking a very keen interest in activities of IACM in the last few years, and we are very lucky to have him as a part of IACM. Welcome you, sir.
Thank you very much.
Thanks. The moderator for today's program is Dr. Arvind Gupta, sir. May I tell you, it's an absolute honor to have you with us. Sir has more than 100 research papers in various national and international journals. He is a recipient of numerous orations and awards, including the prestigious RSSDI oration of 2008, Professor Naresh Bu oration in 2017, Dr. KG Nair oration in again 2017. Sir is the immediate past president of Rajasthan chapter of RSSDI. He was the organizing secretary of the annual conference of RSSDI, and sir is also a member of the project review committee of ICMR in New Delhi. We welcome you, sir. And now I hand over the mic to our moderator, Dr. Arvind Gupta, sir, for further taking the session further.
Thank you. Thank you, Dr. M.M. Singh, for the kind introduction, and respected Dr. Parekh sir, Dr. S.K. Sharma sir, Dr. Pradyuman Sharma, Dr. Puneet Saxena, and all my dear colleagues, delegates, seniors. I think this is the very important session today, and I can say it is a marathon sessions will be there for 2 legends, by the 2 legends, Dr. Virmani and Dr. Shashank Joshi. I request Dr. Pradyuman Sharma sir to introduce Dr. Virmani sir. I know he is the person who is omnipresent any conferences in the country. Dr. Pradyuman Sharma sir, please introduce.
Sure.
Dr. Virmani.
Thank you, Dr. Arvind, my dear brother. My due regards to Dr. Parekh sir, Dr. S.K. Sharma sir, and Dr. M.P. Singh. It's my privilege to be over here to introduce Dr. Anil Virmani. He's a big personality and a great friend. And the point is this, he has many other fellowships to his honor, to speak with DRM, FICP, FIACM, FACP, FDI, FR, SSDI, FACCMD, FISH, CCO. He is a consultant physician and cardiodiabetologist, Jamshedpur, President, Clinical Cardiodiabetes Society of India, Chairman, Indian Association of Clinical Medicine, Jharkhand, faculty, New York Shire Foundation Teaching Program, UK, Faculty School of Diabetes, PHFI, Advisory Council members, ACP East Zone, Executive Council member, East Zone, RSA. And he has published a number of papers in API, SDI, update textbooks, JIMA, JAPI. And the biggest, what I have seen is that he is cyber crime intervention officer, which I was never aware of. So I request Dr. Anil Virmani, who will be addressing on oral hypoglycemic agents and diabetes, which, when, why, and how. Over to you, sir.
Just a word for all the colleagues here. We want these sessions to be very, very interactive. So please write the questions in the chat box, and I'll actually keep all the speakers very busy with the interactive, very, very important questions. So please be ready, Dr. Birmani and Dr. Joshi, for the questions from the delegates.
Sure.
Now, Dr. Virmani, please.
Thank you, sir. Respected seniors and dear friends, at the outset, I'm grateful to Dr. Parikh, sir, and Dr. MP Singh for giving me this golden opportunity, not only to speak on the national scene, but in the same platform with a legend like Dr. Shashank Joshi. Now, the topic that I have been given today is oral hypoglycemic agents in type 2 diabetes, which, when, why, and how. There are too many questions to answer, and I'll try to finish within the given time. I have no disclosures. I will talk only on science and give you a balanced view. What I intend to do in the next 30 minutes is basically to talk in 3 stages. The first stage is going to cover the broad principles of glycemic control that we should all be following. The second stage, I'll give you an overview of all the oral drugs that we have. And in the last third stage, I will tell you how to pick which drug for which patient. Now, we must start with the clinical cases because that is where the whole science is there. Now, I'm going to give certain cases. Let's look at one case, asymptomatic 30 years old male, diagnosed on routine checkup, a fasting 160, PP 220, A1C 8, BMI 23.5. Now, this is a routine case that you see in your clinical practice. Let's look at another case, female. Now, here the duration of diabetes is 2 years. Glycemic control is similar, but there is a high BMI of 30.5 kg. Third case, 45 years old male, duration of diabetes is now 10 years. Similar glycemic control, BMI of 23.5, but serum creatinine is 2.9, eGFR is 30, and UACR is more than 300. Fourth case, 65 years old male, duration of diabetes 15 years, high blood sugars, A1C, BMI 25, uncontrolled blood pressure, LDL, history of triple vessel disease, post-CABG, LVF of 30%, left hemiparesis recovered. This is another spectrum that we see. 55 years old male, duration of diabetes 10 years, high blood sugars, BMI 25. He is already on glimepiride 4 milligram and metformin. He has an acute MI, undergoes PTCA, and sent to you for sugar control. Now, these are the 5 common scenarios that we often see in our day-to-day clinical practice. And at the end of my talk, I will tell you which drug we'll be using in each. But here, there are certain things that I want to tell you. What are the variables that we have to discuss? Are we going to have intensive glycemic control in all as compared to multifactorial intervention? Which drugs are ideal in obese patients? Which drugs are safe in chronic kidney disease? Which drugs are cardio-safe? And which drugs reduce cardiovascular events? Now, these are the factors that we have to consider. When I started my practice way back in 77, life was very simple. You all know that metformin was introduced way back in 59, but the United States took it up in 90s. We were using it in late 70s also. And the guidelines are very simple. Start with metformin unless the fasting sugar is very high. If not enough, add sulfonylurea. If not under control, stop both, start insulin. Very easy to remember, but not patient-centric. A lot has changed since then in the last 40, 45 years. There has been a paradigm shift in the treatment from the classical triumvirate to a near concept of ominous octet, egregious 11, 50, filthy 15, etc. From being glucocentric, we have come to be patient-centric, complication-centric, and now we are heading towards adipocentric. There are a variety of therapeutic agents in our armamentarium. Majority of them have similar glucose-lowering efficacy in the short term. There is a distinct adverse event profile due to specific mechanism of action or potential off-target effects. And there are a number of drugs all of you are well aware of. Now, what has this 25 years of outcome trials in diabetes taught us? Number one, intensive glycemic control, that is getting an A1C of less than 7%, reduces microvascular complications in both type 1 and type 2 diabetes, especially in recently diagnosed diabetes. The impact of glycemic control itself on macrovascular complications in diabetes is small and solely on non-fatal MI, but it requires long-term efforts before it is detected, as we saw in the EDIC and UKpedia study after 30 years of follow-up. And there is now data to suggest that there is actually an increased risk of CV mortality when overtly stringent strategies of glycemic control are employed in high-risk type 2 diabetes patients. So in patients with type 2 diabetes and cardiovascular disease, or those at high risk, novel strategies are required to reduce the CV risk. And we go back to the famous landmark Steno trial, Steno 2 trial, where the intensive therapy consisted of dietary intervention, exercise, smoking cessation, RAS blockers, glycemic control, hypertension, lipids. And there was a 50% reduction in the CV events in type 2 diabetes. At the end of 22 years, after a follow-up of 8 years of intensified multifactorial target-driven treatment with our patients of type 2 diabetes with microalbuminuria, there was an 8 years gain of life, which was free from incidental cardiovascular disease. We all remember Steno 2, but many of us don't know about JDOIT 3 study. This was the Japanese study, which was 16 times larger than Steno 2 trial. And their targets were more stringent, A1C of 6.2. It was basically a pioglitazone-based therapy, a blood pressure of less than 120/75 with RAS blockers and good lipid control. It is a strong statin bias. And after 8.5 years of treatment, there was a 24 significant reduction in the primary outcome, 58% reduction in stroke, 32% in nephropathy, and 14% in retinopathy. So the message I want to give you here is that the optimal approach to the reduction of cardiovascular risk in diabetes should focus on aggressive management of the standard cardiovascular risk factors rather than on intensive glycemic control. Once we have this concept in mind, the things become easy. Now, when we look at the evolution of diabetes care, from glucose-centric looking at only A1C, we started looking at complications like atherosclerotic cardiovascular disease, chronic kidney disease, and heart failure. And today we are becoming more pathogenesis-centric. We're looking at obesity and insulin resistance. There are a lot of factors, other factors, which we have always ignored. Environmental factors, employment, education, food and nutrition, physical activity, gender, bias, racism. And there are, of course, access and affordability as far as healthcare drugs and diabetes technology is concerned. If we look at the anti-hyperglycemic drugs, what are we looking for basically? Which decrease the risk of comorbidities and complications like ASCVD, CKD, and heart failure, GLP-1, RA, and SGLT2. What causes weight loss? Of course, the injectables, GIP, GLP-1, GLP-1 RA, more than SGLT2, metformin. And glucose lowering, we know the injectables, insulin, and GLP-1 RAs are far superior, but all other oral drugs are almost having similar glucose lowering efficacy. Of course, there is undoubtedly lifestyle and management of overweight and obesity are the fundamental principles of diabetes care. So what are the variables we have? We have to look at the patient first, his age, duration of diabetes, what are his comorbidities, what is his risk of hypoglycemia, life expectancy, presence of established CVD, patient preferences, resort and support system. And then and only then we come to, I call it our target A1C. That means the patient has to be involved. It is a decision taken, shared decision between the doctor and the patient that what level that we want the A1C to go. And then we choose a particular anti-hyperglycemic agent. The basic goal is to reduce both micro and macrovascular complications with minimal risk of hypoglycemia. So drug choice is basically patient-centered, efficacy, safety in comorbid conditions, synergistic effects, pleiotropic effects, no hypoglycemia, no weight gain, cardiovascular safety, patient preference, cost, and adherence. Now, when we look at the various drugs that we have, and I'll come to them one by one later, the results of various CVOT imply that the type of drug used to achieve glycemic control does matter, because the total effect of a drug is not entirely conveyed by its effect on glucose levels. As a result, the diabetes field is moving away from its historical reliance on surrogate markers like A1C and fasting and PP blood sugar towards studies that assess outcomes such as heart disease and mortality to identify drugs that can achieve the goal that we are looking at today. Coming to the second part of my talk, the drugs, metformin was the first one, and it was way back in 1998 when it was published in Lancet, the UK pediatric study, and it was a very small group of obese type 2 diabetes patients. There was a reduction of 39% in MI, 36% death, 50% in coronary deaths. And this effect was sustained, though slightly reduced in the 10-year post-trial follow-up. Now, this drug would not have passed the FDA standards today, but that time we did not have the FDA standards to compare with. So way back in 1998, the UK pediatric study group recommended that metformin should be the first line of pharmacological therapy of choice in these patients. Now we have 60 years of experience. It is now that its first and top hierarchy is being threatened by other drugs. But we must remember that metformin still remains one of the gold standards in the treatment of diabetes. And it is very important to know when to use it, especially in patients of chronic kidney disease. If the eGFR is more than 60, no problem. Between 45 to 60, continue use, but monitor renal function. 30 to 45, prescribe metformin with caution, reduce the dose to 50%, monitor renal function, and do not start new patients on metformin if the eGFR is less than 45. Less than 30, stop metformin. Of course, there are other conditions like acute kidney injury and fluctuation in renal status where metformin has to be stopped temporarily. Sulfonylureas, we had used earlier tolbutamide, glibenclamide, but today, since 1995, we have the modern sulfonylureas, that is glimepiride and gliclazide. We have now extensive clinical experience. They are very potent oral agents in the early stages, can reduce A1C by almost 1.5 to 2%. And there is the UK pediatric study did show a decrease in the microvascular risk, though all the randomized controlled trials have not given any bad signal and they are affordable. That is a very big factor. But they are glucocentric and not disease-centric. There is less durability, possible beta cell apoptosis, which has now been challenged. Secondary failure is common, risk of hypoglycemia and weight gain. And we have to reduce the dose in renal impairment and avoid in hepatic failure. And this is the mortality systemic review and network meta-analysis about mortality risk among the various sulfonylureas. And we see the modern sulfonylureas, gliclazide and glimepiride are very favorable. So what are the indications? Earlier, it was said that they are effective second-line agents after metformin. And we must be using modern sulfonylureas to reduce mortality, less hypoglycemia, better CV outcomes and renal protection, that is either glimepiride or extended release gliclazide. And they should be initiated early in the course of type 2 diabetes if we want to achieve maximum glycemic benefits and obtain the benefits of metabolic memory or the legacy effect. The main problem is with weight gain and hypoglycemia, but when you combine it with metformin, the weight gain, at least there is mitigation. Now, fixed drug combinations can improve adherence and offer an inexpensive, and more efficacious option. Unfortunately, they are not in any international guidelines because the ADA and the AC group have grouped all sulfonylureas into one class and they have not taken their dissimilarities. And this simplistic choice prevents the advantages of modern sulfonylureas from being highlighted. Now, why they are better in the new onset type 2 diabetes? As I said, rapid reduction of A1C will reduce not only glucotoxicity, but can help in prevent long-term risk of complications. And there is an early achievement of glycemic control leading to legacy effect and better outcome. And there is a study which shows that the A1C more than 6.5% during the first year of treatment are at a higher risk of micro and macrovascular, while those with more than 7% during the first year had a higher mortality risk. So immediate intensive treatment for newly diagnosed patients may be necessary to avoid irremediable long-term risk for diabetic complications and mortality. And if you look at this, the earlier you start, less than 5 years is the green one, and from diagnosis, the less the mortality, and this is red one is more than 10 years, and this is 5 to 10 years. So the mortality increases as the duration of diabetes increases. Coming to the next drug, pioglitazone, introduced in 96, best insulin sensitizer, very rare hypoglycemia, very high A1C efficacy, durability is there, favorable lipid profile. The proactive trial, the secondary endpoint showed reduction in MI, stroke, and CV death. And there is the IRIS study in patients with TIA, history of recent stroke or TIA, and insulin resistance, even without diabetes, there was increased risk of stroke and MI. But there are a lot of problems with pioglitazone, like weight gain, edema, heart failure, bone fractures, especially in postmenopausal women, macular edema. But fortunately, it's a very important agent from the Indian perspective due to the high prevalence of insulin resistance in the Indian Asians. So a judicious selection of patients and pharmacovigilance is required. And this study published in BMJ in 2016 has totally rubbished claims of any relation to bladder cancer. And the renaissance of pioglitazone took in 2016 after the IRIS study, where it was shown reduction in stroke and TIA, absolutely wonderful reductions. Coming to the next drug, AGIs, which are again not in any international guidelines because they're used only in our country. We have acarbose and voglibose. They decrease the postprandial glucose excursions. There is a dual mode of action. It inhibits not only glucose absorption, but also increases GLP-1, no hypoglycemia, no weight gain, and especially it's very suitable for us because India, we all know, is a high carbohydrate consuming country. The average daily intake of carbohydrate is around 65 to 70%. Unfortunately, there are certain GI side effects which are now mitigated the way you give the medicine along with the meals and even with voglibose as compared to acarbose. You have to give it with every meal, and there's a modest A1C efficacy. A consensus statement on this was published in the JAPI in 2015, and it has said that we, especially in Indians, because of the high carbohydrate, it's a good drug, takes care of postprandial hyperglycemia, can be used even as first-line drug in combination with all the other drugs and gives you a favorable. It also takes care of the fasting through the ceiling effect. DPP-4, we had sitagliptin in 2006, then we had saxagliptin in 2013, then of course the generic ones, teneligliptin and now evogliptin. The reduction, as I said, is almost similar to everyone, but these are basically weight neutral. Low risk of hypoglycemia. In fact, side effects are as good as any placebo. And it is said, like during the COVID era, if you wanted to give any anti-diabetic drug through teleconsultation, DPP-4 was the safest. CV safe, it has got possible pleiotropic benefits, beta cell production. There is a theoretical risk of pancreatitis, but very rare, avoid in patients with history of pancreatitis. Arthralgia has been same. One should be have a high index of suspicion. Angioedema, saxagliptin and alogliptin possibly had increased risk of hospitalization for heart failure, but not sitagliptin, and possible off-target effects. And if you look at the aggregate 11, it has got multiple effects on majority of the defects, pathophysiological defects. So how they score? Comprehensive mechanism of action, dual targeting of alpha and beta cell, glucose dependent insulin secretion, so less risk of hypoglycemia, weight neutral, and they stimulate beta cell neogenesis, reduce beta cell apoptosis, and thus preserve beta cells. They work smart only in response to increased glucose, and they are also known to reduce glycemic variability and cardiovascular safety. In addition, renal and hepatic safety profile makes it makes gliptins a very attractive choice. Coming to the game changer, SGLT2 inhibitors introduced 2013, 2014. We had CANA, EMPA, and now even DAPA. Again, the A1C reduction is at par with the others. Durability is superior to sulfonylureas, effective at any stage of diabetes, but should be avoided in insulinopenic patients for fear of euglycemic diabetic ketoacidosis, least hypoglycemia, superior weight loss to metformin and gliptins. There's a robust blood pressure reduction, cardiorenal benefits of enormous significance. But look at the side effects. GMI, UTI, genital infections, volume depletion, especially with loop diuretics, postural hypertension with RAS blockers, question of safety in elderly, but now it has shown that it can reduce cognitive decline, deteriorating renal function, they don't work. There's paradoxical increase in endogenous glucose production due to increased glucagon insulin ratio. There are unfavorable increase in LDL, but not very clinically significant. Increased breast and bladder cancer with DAPA, again, very controversial. So if you look at the glycemic benefits a lot, insulin independent mechanism of action, reduction of all the parameters, durable, we can achieve glycemic goals, no hypoglycemia. But what is more important that we require is the extra glycemic benefits of pleiotropic effects, like weight reduction due to calorie loss, blood pressure reduction due to osmotic diuretic action, increase in HDL and reduction in triglycerides, cardiovascular and renal protection. So I gave my 10 commandments of using the SGLT2 inhibitors. Before starting, always assess volume status, measure eGFR in all patients. It is recommended in eGFR more than 20. Take a proper history of recurrent UTI and genital mycotic infections and document it, because that is very important today. It can be started as a monotherapy, very appropriate in Asian Indian phenotype, can be given safely at every stage, as I have said, but avoid in severe insulinopenic patients, contraindicated in pregnancy, lactation, severe hepatic impairment. Regular monitoring of self-monitoring of blood glucose should be advised, especially if the patient is also on insulin. The most important thing is educate the patients about its side effects, meticulous genital hygiene, adequate hydration, and proper foot care, and then you will not face any problems. Have a shared decision making, and that is very important. And patients should be instructed to report any stressful condition, including foot ulcers. Concomitant use of potent diuretics and insulin, the dosages should be adjusted. So if you follow these 10 guidelines, 10 commandments, there is no problem in using SGLT2 inhibitors. Now we have robust data for secondary prevention. And if you don't use it, they're as good as statins and aspirin. And if you don't give it for secondary prevention, it may be termed as medical negligence today. But what about primary prevention in patients? Now, primary prevention is also supposed to be good, but we do not have enough data at the moment to recommend it for primary prevention. Coming to the another drug, oral semaglutide, which is basically a GLP-1, which is available to us only as injectable. This is the first oral GLP-1 RA. It has got all the benefits of GLP-1, glucose-dependent stimulation of insulin secretion, reduces glucagon release, reduces hepatic glucose output, delays gastric empty, increases satiety, And there's a modest reduction in A1C, body weight systolic, low risk of hypoglycemia, and it is CV neutral. But the problem is with the dosing schedule and conditions, and creates a lot of discomfort from the patient's perspective. Dose-dependent GI side effects can lead to almost 15% drop-offs. And there was no significant positive benefit in the Pioneer 6 trial as compared to with the injectable semaglutide. But the biggest problem with our Indian patients is the cost and affordability. The last drug is imeglimin. It basically is an oral inhibitor of mitochondrial oxidative phosphorylation. It targets mitochondrial bioenergetic in beta cells, liver, and muscles, leading to the various metabolic effects, restores myocardial dysfunction. It's got a unique mode of dual action with being both insulinotropic and insulin sensitizing. So both it increases insulin secretion, also increases insulin sensitivity. It is not recommended below 45 ml. Similar efficacy as metformin. It was initially introduced that it can be used in patients who are intolerant to metformin, but now it is said you can even combine it with metformin and you can combine it with any other drug you want. The largest study was of 52 weeks, so we have to be pharmacovigilant about lactic acidosis and other side effects. And the A1C reduction is modest, almost 0.9%. These are the Stumwall and Matsuda index for insulin sensitivity. It is far superior. It is a good insulin sensitizer. And one of the wonderful things is, in combination with metformin, it gives the best result of 0.92 A1C reduction. So it doesn't matter which drug you use, the glycemic efficacy, as far as the glycemic efficacy is concerned, almost similar results. If you look at this, A1C of less than 75%, whether sulfonylurea 60%, DP4 62, glitazone 63. So all almost similar, not much difference as far as glycemic efficacy is concerned. Now, one word about OAD failure. When A1C remains above goal, you are using 3 drugs, 1 metformin, 2nd preferably sulfonylureas, adequate diet, exercise, no comorbid conditions, and for hyperglycemia, it's OAD failure. It can also be there when patient goes into uncontrolled glycemia and insulinopenia. Primary OAD failure occurs within 6 months of diagnosis, after 3 months of initiation of triple therapy, and secondary after adequate response for at least 6 months. So now that finishes a broad overview of the drugs. Now, how to choose the drugs in different patients? And this is the AC guidelines, American Association of Clinical Endocrinologists, which I tend to follow mostly. Of course, lifestyle intervention is very important. They are a bit stringent and risk. Now, independent of glycemic target and other type 2 therapies, as I told you earlier in my first part, it is not necessary to have intensive glycemic control in each and every patient. So a patient is having atherosclerotic cardiovascular disease or high risk, then you give preferably a GLP-1 RA first, or if not, then SGLT2. Heart failure, drug of choice is SGLT2 inhibitor. In patients with stroke or TIA, is GLP-1 RA or pioglitazone. Pioglitazone has come up like anything. CKD, SGLT2 first, and then GLP-1 RA. And then you individualize the glycemic targets, and they say you get it below 6.5, but it can be 7, 8, depending on the comorbidities. Metformin, either you can start or you can continue with what you started earlier. And then if glycemic control is not optimum, you can add one of the other drugs. They say the A1C is more than 7.5, start with 2 drugs, more than 8.5, start with 3 drugs, more than 10.5, go straight to insulin and GLP-1. Now, once you have started, if you're still looking for glycemic control, or in patients who do not have these factors, then what are we looking at? We're going to look at overweight or obesity. And there, where the drug of choice is either the GLP-1, GLP, or SGLT2 orally. Hypoglycemia risk, again, same drugs. If you're looking at the cost, then glitazones, sulfonylureas, or glinides, Now, sulfonylureas have been mentioned by AC as a cost factor. In patients with severe hyperglycemia, go straight for insulin or GLP-1 injectables. And you can add DPP-4 or whatever is left behind so that you ultimately get an optimal glycemic control. Basically, it remains the same. Now, ADA-ESD, which majority of the doctors follow in India, this is the latest update. They are basically saying same things, but only thing they've added here is that for patients on GLP-1, they combine SGLT2 with proven CVD benefit, or you can have a combination of these two together for better benefit, and they have put again zones in their list. But very important, glycemic management with whatever drugs you want, and you can use other drugs if this part has been taken care of. Then weight management, set individualized goals, lifestyle advice, structured weight management programs, medication, bariatric or metabolic surgery. You can use GLP-1 receptor agonist injectables and other weight loss drugs.
Sir, you have 2 minutes.
Yeah, I'm almost finished. Then the 223 ESC guidelines have given the similar things. If you look at this, GLP-1, SGLT2, and Finranon in CKD all have class 1 indications. This is independent of glucose control and in addition to standard care. So the priority remains the comorbidities. And then you look at the various other factors that I've just discussed. And this is the RSSDI wheel that some of us have been following. And it has divided into age, BMI, CKD, the degree of duration of diabetes, established CVD, the finance, glycemic status, and hypoglycemia risk. The closer to the center, more drugs can be used. The further you go from the center, the choice becomes limited. So now we have a new paradigm. Besides exercise, diet, early pharmacotherapy, utilize agents in combination to target multiple physiological defects, minimal hypoglycemia, minimize weight gain, try to preserve beta cell function, and maximize insulin sensitization. So ideally, a prescription should have a balanced low-calorie diet, exercise, and a combination of any of these drugs, metformin, glitazone, GLP-1, or SGLT2. Now, coming back to those cases, first case, new onset diabetes, metformin plus sulfonylurea. You can add, but lifestyle modification remains same in all. In patient who is obese, you add metformin plus SGLT2, or if the patient can afford it, oral semaglutide, and you can keep on adding. In patients with chronic CKD, SGLT2, linagliptin, you can use low-dose glyphosate or glyphosate, but Finranon is another important addition here. In patients with multiple comorbidities, metformin plus GLP-1 RA and SGLT2 should be the initial combination. In patient who has got a PTCA, he must get metformin plus GLP-1, and then you can add as an SGLT2 or DPP-4. But all patients should be on statins and holistic approach. So certain clinical pulse, if the duration of diabetes is less than 5 years, go for strict glycemic control. If it is more than 10 years, be complication centric. Optimal glycemic control in between is a gray zone, and holistic approach involving almost everything from hypertension, dyslipidemia, obesity, diet, smoking cessation, alcohol abuse, stress control, meditation, yoga. Now, key messages that I want to give you. Indian Asian diabetics are essentially different from the Western population and require a more aggressive approach. Set realistic targets, regularly monitor them. There are a lot of factors in drug selection, but in India, cost is very important. Clear benefit in treating early and maintaining a tight glycemic track record. Avoid procrastination, attain target within 3 to 6 months. More proactive aggressiveness, early combination therapy, timely insulin initiation, hit early, hit hard. Access and affordability have to be balanced. Modern sulfonylureas will remain in our armamentarium, especially in early onset diabetes, but even as an add-on after you have added the preferred drugs. Early combination is the only answer to this menacing problem. multiple risk factor intervention, patient-centric approach, teamwork, important. And the last final message I want to give you, when all options are relatively safe, given the benefits they confer, therapeutic decision-making must rely on a personalized approach, taking into account patients' clinical circumstances, phenotype, pathophysiological defects, preferences, abilities, and costs. The overarching goal should be safely achieve glycemic control at the earliest possible stage with the least risk for adverse events. But the most important message is that selection of one agent over another is not as important as implementing some form of early intervention and advancing rapidly to some form of combination therapy as and when needed. Thank you for a patient hearing.
It was an excellent deliberation. I think you need the great applause. You have left no stone unearthed for deliberating the oral hypoglycemic agents. I think we will take questions later on. Dr. MP Singh, I'll take after Dr. Shashank Joshi's deliberation. Dr.
Yes.
MP.
Sir, as you wish, sir.
I think we will take questions after the Dr. Shashank Joshi session.
No problem, sir, as you wish, sir.
Because there are storming sessions, I know. Dr. Virmani, just be ready for that, okay? Now I request Dr. Puneet Saxena to introduce none other than Dr. Shashank Joshi, the great legend.
Good evening, everybody. And we just heard a very excellent deliberation from Dr. Virmani, where he covered all about the oral hypoglycemic agents. And further continuing with the management of diabetes, now we want to hear from Shashank Joshi about the insulins, what are the types, how to use, when to use. And we all know Dr. Shashank Joshi, what a legend he is. He has been past president of API. He has been past president of RSDI. He has been past chair of IDF South East Asian region. And he has been get so many accolades and awards that's very difficult to enumerate. But just to say that he has more than 1,000 publications, that is whopping and enormous. And he has been editor of JAPI, and he has, I don't have any words actually. He has been editor of textbook of API of medicine, and he is a renowned endocrinologist. He's been awarded Padam Shri, just to quote one of the awards, which is one of the highest awards from Government of India in 2014. And he has, on a personal note also, he has been a teacher and a mentor and a friend of mine, and I have very high regards on the personal note also. So I welcome Dr. Shashank Joshi to please enlighten us with his talk.
Thank you very much, Puneet ji, for your kind words of introduction. Thank you, Dr. MP Singh, and Dr. Arvind Gupta. I must thank Professor Dr. K.K. Parikh, Dr. Girish Mathur, and the entire team from IACM, and particularly Dr. K.K. Parikh for keeping diabetes at forefront. And I must congratulate Dr. Virmani for a very nice book. The topic allotted to me is insulin types, how and when to start, titrate, and taper. And that is a challenging issue with the clinicians. Unfortunately, now the number of oral agents have gone up so much that people, the old dictum to use insulin was, if 2 or 3 oral agents at 50% of their dose do not get your A1C down below 7%, then that's the ideal time to use insulin. Now, remember, there are 4 types of diabetes. There is type 2 diabetes, which is 90% of the diabetes we see. But in type 1 diabetes, in gestational diabetes, as well as in diabetes, which is secondary to diseases of pancreas, there is no C-peptide on board. And if there is no C-peptide on board, you need to give insulin. So the treatment of choice for type 1 diabetes, for gestational diabetes, as well as secondary diabetes with pancreatic disease is clearly insulin. But a large proportion of type 2 diabetes, after 2 decades or 3 decades, the beta cells may fail, and you may need insulin again. So remember that a most simple yardstick to know whether the beta cells are producing insulin or not is you can do a meal stimulated or post-breakfast C-peptide or a basal and C-peptide. If the C-peptide is low, you are not making insulin in your body and you need to take insulin. Unfortunately, a lot of our population with type 2 diabetes who need insulin don't get insulin. And a lot of them who are insulin resistant keep on taking insulin. But today, that's not the domain which I'm going to do. The topic allotted by Dr. Parikh to me is the types of insulin, how, when to start, titrate and taper. So some background of insulin therapy. We know insulin is the longest surviving anti-diabetic drug. And the challenge with insulin is that it is more than 102 years old after its discovery. And before discovery of insulin, there was only probably diet and lifestyle. And people used to die due to lack of insulin, in particular type 1 diabetes space. So it's really there. Sulfonylureas only came probably 50, 60 years after discovery of insulin. Because accidentally in World War II, they discovered due to sulfonamides, there was hypoglycemia and they discovered sulfonylureas. Then came metformin. But in the last 2 decades, we saw an explosion of drugs which Dr. Virmani covered. So clearly, I will talk on insulin background. I'll talk of types of insulin in initiation and intensification and dosing and titration of insulin. But in general, due to the plethora of anti-diabetic drugs, the 3 I's for insulin, which is my talk, is there is an inertia. We are reluctant to use insulin. But remember, if you have glucotoxicity, if you have A1C, which is above 9 or 10%, if you have cachexia or catabolic state or a acute state, probably insulin is the drug of choice. So clearly recognizing that, we all know that our beta cells make insulin, and insulin is secreted in a biphasic fashion. The first phase of insulin secretion fundamentally is the early phase, and usually in type 2 diabetes it is lost. And what insulin does is that in the first phase, when it is secreted, typically it suppresses the hepatic glucose output and restricts the prandial glucose elevation. And fundamentally, it induces the second phase of insulin release, which is the plateau phase. And the second phase is required for processing of newly synthesized insulin, and then the priming of insulin secretory vesicles from the beta cells. And what happens in type 2 diabetes is that the first phase of insulin secretion is lost or is almost entirely absent. And the second phase is reduced more than 50%. So clearly, when we are going to eat and all of us are going to have dinner, I may be a detrimental or the barrier between you and dinner. The insulin is secreted in a biphasic fashion in response to glucose. The first phase, which is suppressing the hepatic glucose output and the prandial insulin curve, and the second phase, which primes the insulin secretory vesicles. So fundamentally, we use insulin around surgery, in inpatient hyperglycemia. We used a lot of it in stress hyperglycemia around COVID times, whenever there's infection or sepsis, whenever there's pregnancy, whenever there's CKD stage 4 or stage 5, or any other chronic illness which is critical. We also know that insulin is a treatment of choice when there's diabetic ketoacidosis or a hyperosmolar state. But in hyperosmolar state, hydration and insulin both go hand in hand. So for type 1 diabetes management, you need insulin. There is uncontrolled type 2 diabetes, or when agents are contraindicated or they are not sufficient, or there is no beta cell on board, we also use insulin. And insulin is a very, very useful drug. And that is the insulin, as I told you, evolved. And we have seen the huge evolution of insulin. In 1922, and we are in 2023, so it's 100 year or 1 or 2 years old, and it was isolated by Banting and MacLeod and Best and Collip, and they shared the Nobel Prize. And then, of course, initially the insulins which were available, probably when we were students and when we were residents also, were the animal insulins, the beef insulin and the pork insulins. And they got extinct. In the last 2 decades, we have seen they got extinct. And the long-acting insulin was not there till 1946. And it was the Hegedron protamine retarded NPH, which was the first long-acting insulin. And in the 50s, we used to have all types of mixtures of insulin, 30-70, 50-50 are the common ones which we know today. But that time there used to be 10-90, 20-60, etc. So originally, technically, insulins got mixed with NPH and regular insulins, and different formulations were made that time based on the time action profile of insulins. Then in 1977, the birth of recombinant DNA technology came in. And we got development of the E. coli based or the fungi based insulins through rDNA, and they were the pure human insulin. So obviously the animal insulin started declining worldwide, and by the last century end, by around 1990s and 2000s, virtually now the animal insulins are not available, and all we get is simple recombinant DNA insulins, which are even made. It's a biotech product, so there are biosimilars made from India and China also. And then fundamentally, we got the rapid acting insulin analogs, and NPH used to cause nocturnal hypoglycemia in 1/3 of cases. But we got the birth of glargine. Glargine is a game changer insulin, 10 units at night at 10 p.m. Used to control the fasting glucose, switch off the hepatic glucose diarrhea. And fundamentally, glargine was a big game changer in insulin development. And after glargine, of course, we have second generation glargine, U300 glargine, or the newer insulins like degludec, which have come in. And of course, the insulin analogs also became rapid acting and fast acting. So we are getting newer and newer analogs. We have the Piasparts and the glucylysines and the Lyspros of the world. So typically, we saw the full 102 years of insulin, a lot of innovation. And of course, oral insulin still remains an enigma. Inhaled insulin came in but went away very quickly. We recently wrote a paper on tregopin, which is oral insulin. But technically, oral insulin is still a far way away. There is one insulin by US Mankind Pharma called Afrezza, which is an inhaled insulin still available. They are short-acting insulins. And of course, we will get once-a-week insulin now called icodec coming up. But fundamentally, for practical purposes as clinicians, because we are all clinicians, we need to understand the basics of insulin for initiation and titration. So currently, what we have available, we have the fast-acting insulin Aspart, Lispro, and Glulysin, and we also have the fast-acting insulin Aspart, which is Fiasp. So those are the rapid-acting insulins. They work very quick and fast. Then, of course, we have the human regular insulin. Then we have intermediate-acting insulin for NPH. Then we have, of course, Detimer, which is usually twice a day, or the Glargine U100. Then we have the U300 Glargine and degludec. Then we have a co-formulation. It's not pre-mixed technically. A co-formulation of degludec and Aspart 70/30. And then we have pre-mixed insulin analogs like Lispro 25/75 or 50/50 or Aspart 30/70 or 50/50. And of course, we have regular premixes also of regular insulin with NPH 30/70 or 50/50. So clearly, if you see the basal insulin analogs, they are the glargine was supposed to be peakless, but it has a small peak. Detimer usually doesn't last for the full 24 hours. But the U300 glargine and degludec are virtually flat. So you can clearly see glargine is once a day, low risk of hypoglycemia versus NPH, safe for the heart. And there's not much flexibility because it has a pH challenge, and therefore that's the big challenge with it. Detimer didn't survive the market. It's expensive. It has a lower risk of hypoglycemia compared to NPH and glargine, but the flexibility was still a challenge, and it didn't survive too much. U300 glargine and degludec, both of them cause very low hypoglycemia. The nocturnal hypoglycemia probably in intensification phase is lower with U300 compared to degludec, but otherwise, more or less, both are excellent insulin which are available to us. The advantage of degludec is you can co-formulate it. U300 glargine, we can't co-formulate it. Then we have these prandial insulin analogs, which take care of the first phase of insulin secretion, Aspart, Lispro, and Glulysin, or the fast-acting Aspart. Both of them have advantages. They control the prandial glucose better. They give you mealtime flexibility, so you can give it after meals, and they have a lower risk of nocturnal hypoglycemia and prandial control. The fast-acting Aspart is supposed to have a little more physiological action on mealtime insulin, and the oral insulin space like Tregopil or the Oramed insulins probably will occupy this space in this area. But I don't personally see major advantage between a fast-acting Aspart or Aspart, Lispro, or Glulysin in terms of time action profile. In type 1 diabetes, it does matter, but in type 2 diabetes, we are not so sure. Then, of course, we have the premix or co-formulations. You can use a 30/70 mixture or a degludec Aspart, and you can see very good steady state levels which can be achieved. So you can use it twice a day, thrice a day, and you can have mealtime flexibility with biophasic analogs. Of course, regular insulins also can be used, and the prandial glucose control with the co-formulation may be a little better because there is no tail, and it can take care of the tail a little better. That's the only advantage. So there are different types of insulin regimens. And the simplest regimen was the BIDS therapy. That is bedtime insulin and daytime sulfonylurea. It was a 30-40-year-old regimen, and you give an NPH or a glargine at night, maybe 8 to 10 units, and look at the fasting blood glucose, try to keep it below 100 or 120, and keep on increasing 2 to 4 units, doing SMBG every 3 to 5 days. And the daytime you can cover it up with a secretagogue. Of course, now Dr. Mirbani gave you a whole plethora of drugs which we can use, but that's the simplest regimen which you can use as a basal insulin. And it used to be also called as BOT regimen. Formerly, it was called as BIDS regimen, BIDS, bedtime insulin, daytime sulfonylurea. Now, of course, we call it as bedtime insulin with oral treatment. So that's how it is called as BOT. Then, of course, the same thing we can give instead of giving basal with the largest meal. Some, different parts of India has different geographies. We did a STAR study. Some parts of India, they may have a large brunch. Some parts of India have a large lunch. Some people will have largest meal as dinner. For example, in Mumbai city, often people skip breakfast and their largest meal is dinner. And then we can give a premix or a co-formulation. Normally try to use this combination with the largest meal of the day. Sometimes we can give twice a day premix also. Physiologically, however, the most scientific way is start with basal, go to basal plus, and give basal bolus. For type 1 diabetes, we need basal bolus. If there is no insulin on board and beta cells are gone, then basal bolus is the ideal. But otherwise, in type 2 diabetes, we use basal, basal plus, premix insulin or a co-formulation, or even twice a day premix or thrice a day premix. Rarely we use. And of course, you can use basal bolus regimens. So once a day insulin, as I told you, is peakless. It controls the fasting glucose next day morning. It can be very easily used with oral anti-diabetic drugs. It suppresses lipolysis, proteolysis, endogenous hepatic production, but it doesn't take care of the prandial glucose. But the old adage was fix the fasting first. So if you fix the fasting, automatically the prandial glucose excursions come down in their area under the curve. So the advantage is that if your A1C is above 8.5, and if you use a basal insulin once a day, it's effective and safe. It's simple to use, less weight gain, less hypoglycemia, and you can get it done quickly. But the prandial curves, because we are a carbohydrate country, sometimes it may need an intensifying regimen, and you may need to use a premix with 30-70, 25-75, 50-50 ratio. And based on what you eat, you can see the basal bolus coverage. And as I told you, it should be given with a major meal of the day or the largest meal of the day. It has its advantages because it's convenient, but it's not perfectly physiological. So you need to, titrate it with the fixed daily routine of lifestyle and carb content and meal timing. Because if you delay it, the flexibility is limited there. And, in the conventional mixture, of course, you have to inject insulin 20 to 30 minutes before meals. But in, the analogs, you can give it anytime. Then, of course, you can use co-formulations. And you can, many people eat 2 major meals. And the co-formulation has lower risk of hypoglycemia. So that's the advantage it carries. And it's easy to use. It's quite flexible from that standpoint. They come all in these novel pens. Of course, the mixtures need to be given before meals. Otherwise, you can give it after meals. The most physiological regimen for insulin therapy, and that's what we use for type 1 diabetes, is the basal bolus regimen, where you initiate with basal, and if there's severe hypoglycemia, with every meal you give the bolus dose. Sometimes we'll end up giving 3 or 4 bolus doses or 5 bolus doses also. Sometimes we have to, that's how the pumps work. So the poor man's pump is a basal bolus regimen. So with every meal, you can give a glucose, and you can actually do the, the insulin to glucose ratio by calculating the carb counting. So basal bolus is very flexible. You can eat at any time, do physical activity, gives you an excellent glycemic control. It mimics physiology. It's pharmacology and it mimics physiology. It controls both the basal and postprandial hypoglycemia. And for erratic lifestyle, it is very, very good. The challenge is when you use basal bolus insulin, you need to learn carbohydrate counseling. You need to learn your insulin sensitivity factor. You need to look at hypoglycemia and weight gain. It needs a lot of cooperation from patients and motivation. If you have SMBG or CGM, and now CGM has made our life very easy. We have the Abbott Libre, we have all these CGMs, and we can easily then handle them better. But these are all expensive otherwise. But it needs a lot of education. So finally, the next question people ask is, how do you dose and titrate insulins? Because we know that, if you don't dose it correctly, you will get hypoglycemia, you will have challenges with weight gain, and so many guidelines exist. So, what do we want from insulin therapy? We want a good glycemic control, which is missed by oral agents, and which prevents future risk of complications. Because tighter the control, the better the likelihood of complications go down clearly. And in type 1 diabetes space, we have 40 years of data now available that with EDIC code of DCCT that tight glycemic control matters. Same is applicable even in the pregnancy space, and same is available in the secondary space. In type 2 diabetes, however, tight glycemic control matters, but there are some relaxations. For example, if you have somebody with limited life expectancy, somebody has a lot of major vascular complications, it has recurrent hypoglycemias, you can go up to an A1C, not up to 7, but maybe 7.5. So you can give a little bit of leeway there and try to, have a minimal insulin burden and try to have minimal hypoglycemia. And the new generation devices are painless. It is less painful than a mosquito bite. See, the threat perception of insulin is very poor. Remember, when you have to motivate people to take insulin, you have to say that it is less painful than a mosquito bite. It's what your actual portal when makes insulin and regulates your glucose metabolism. So it is the natural substance. It is like, people want Ayurveda. I would say that the natural substance which our body makes to regulate glucose is insulin. So it is the oldest living anti-diabetic drug on planet Earth. It is natural what our pancreas makes. It is bioidentical in terms of its time action profile with the newer analogs. And fundamentally, it doesn't have an upper dose threshold. You can use any amount of dose to get your glucose under control. The only rate limiting step for insulin use is extension of its action, which is hypoglycemia, and of course weight gain. And those are the two major issues. Of course, in the good old days, we used to get a lot of other things like lipodystrophy, allergies, and so on and so forth. So how do you initiate insulin? What should be the starting dose? At what time of the day should the insulin be started? How should we relate it with the meal intake? Because it's a meal dependent. Then what device to choose, how to inject, and how to adjust the dose of insulin. So usually the starting dose for a basal insulin is 10 units at 10 p.m. and next day morning is 100. So it's 10, 10, and 100 or 0.1 or 0.2 units per kg body weight is a dose if you really want a body weight kg dose. What time it should be given? Basal insulin can be given at a fixed time. It is not meal independent. It is meal independent. Why? If you are giving a short acting or a co-formulation, try to give it before meal. If it is a regular insulin, at least 20 to 30 minutes. And if it is analog, you can even give it with meal or after meal. How do you adjust the dose? You need SMBG or CGM or a fasting BP glucose, and you need to adjust it every 3 days with the help of it, and you can minus or plus 2 or 4 units based on it. It's always given subcutaneously. Of course, you can give it IV also. Remember, in IV, it doesn't matter. Whether you use regular insulin, whether you use a analog, it doesn't make any difference because the IV action is the same. And which device to use? Of course, we have very good pens available. We can use a syringe and needle also. You have U40 and U100. Never mix the two up, and that's easy to use. So remember, insulin can be given sometimes at diagnosis. For example, if you have symptomatic hyperglycemia, organ dysfunction, metabolic decompensation, ongoing weight loss, symptoms of hyperglycemia like polyuria, polydipsia, polyphagia, A1C is about 10% and persistently glucose is about 300. You are planning pregnancy or during pregnancy, I think insulin can be given at diagnosis also. It will settle the glucotoxicity, and that's what the RSHA guideline says, and you can easily use it, and it's not difficult to use. So the guideline recommendations are very clear. Insulin has a very high efficacy, and it is recommended in people who do not achieve their glycemic goals on metformin or other oral agents, and they don't have any major cardiovascular or renal compromise or weight management considerations. So if you see the guidelines of 2023, fundamentally, if it is very high on efficacy, and we need to avoid hypoglycemia and in high risk individuals. So remember that in the high efficacy approach, it has a pecking order with the GLP-1 analogs, dual agents, triple agents, or a combination of insulin with GLP-1 receptor agent can also be used. But insulin is right there in the very high category for efficacy. So in the highest category of efficacy, insulin is right up on the pecking order. And that's something which we need to recognize. Well, what else? Well, can you initiate basal insulin after injectable GLP-1 receptor agent? Yes, because we are going to use more and more of that. And you can see that if you need an injectable therapy to reduce A1C, you can start a GLP-1 or a dual agent in most individuals prior to insulin. And then, you can initiate the appropriate starting dose for the agent, and it varies with class, and titrate it. And if the A1C is not on target, then you can add a basal insulin and look at the insulin. And normally, as I told you, the initiation dose is 10 units per day or 0.1 to 0.2 unit per kg day dose. And next day morning, see the fasting. And there's an evidence-based algorithm for that. You increase 2 units every 3 days till the fasting comes to target. And if for hypoglycemia, reduce the dose by 10 to 20%. Of course, IACM, ESI also came out with their own consensus. Break the treatment initiation. Insulin should be given to all patients where the glucose goal is not achieved with 3 agents. So if your triple drug therapy cannot manage it, really don't struggle with another agent. Offer it to the patients. Tell them that it's a natural substance of the body. It's an anabolic substance. It improves and causes weight gain. And it can be very good for people who are catabolic, who get recurrent infections, who are low on immunity. It's a very good agent. And usually, we can have a 3-step protocol of initiation, titration, and intensification for all people who need insulin. So initiate with a basal insulin or once a daily premix or a co-formulation or a twice a day premix insulin with or without oral agents. Look at the age, clinical features, glucose profile, risk of hypoglycemia, and patient preference. And basal bolus regimens can be given in severe cases or when there is life-threatening or organ or limb-threatening situations, and particularly when there is diabetic foot and other infections. So what are the options for insulin initiation? We can give basal insulin. It's easy to use, simple and easy, and facilitates management. If you can't get that control, particularly on the prandial glucose, then you can use a basal bolus therapy. It's a gold standard. It closely mimics normal physiology, but and clearly it's more complicated, needs used to low carbohydrate counting. You need to have a CGM or a SMBG for hypoglycemia. You need to monitor weight. And sometimes, sometimes we can use it even directly at diagnosis. And of course, now to balance between the two, we use sometimes a premix or a co-formulation by balancing fasting and prandial glucose. It's easy to teach, convenient, but sometimes it's cumbersome because it needs a lot of titration on lifestyle. So when you initiate, it again depends on the age. Are you a child? Are you adult? Are you elderly or in pregnancy? For example, if you are a child, the approvals are different. For example, aspart is approved about 1 year, dispro about 2 years, glulysin about 6 years, fast aspart about 1 year, then NPH or detimir about 1 year, glargine about 2 years, degludec about 1 year, glargine U300 about 18 years. So you need to understand that for children, the approvals are different, but basal bolus is normally the regimen we use for children with type 1 diabetes. For adults, you can use basal, basal plus, basal bolus, or a premix. For elderly, probably we tend to use more of basal, and we need to be mindful of hypoglycemia. Remember, some of the newer analogs like U300 glargine or the degludec are more safe when there is a renal compromise or in senior citizens because they cause less hypoglycemia. And in pregnancy, of course, you can use basal bolus insulins, but normally, we try to keep it simple in pregnancy. So as I told you, what is the preferred insulin regimen? It has to be patient-centric. For example, if you are looking at a premix insulin, particularly we look at if the prandial glucose is very high, more than 54 grams, or the fasting to A1C ratio is less than 20, or if the beam value is more than 55, then you add and take that prandial component of the premix insulin. There are psychosocial factors. For example, some people are very reluctant to use insulin. You need to teach them. You need to teach the caregiver sometimes, their children or their parents, if they can't handle it. And based on the disease status, we can look at it. And also remember that insulin needs education. There is a cost involved into it. We tend to eat a lot of carbohydrates, so we need to be mindful of it. It also causes a lot of hunger. Basal insulin is very good. Again, there are various factors where we use it. If patient is a child, we use a basal bolus therapy. In an adult or a pregnant lady, also we can use it. It's very good to control fasting in elderly population. But again, resource limited settings, we need a lot of education in it. So as I told you, the choice of insulins are huge, and we have different approvals in place. For example, regular insulin, for bolus regimens, 4 units is the standard dose. You can go to 6, 8, 12. Usually for regular insulin, 30 minutes before meal. And of course, for glulysin, lispro, aspart, you can just give it before or after meal. And for FIASP, you can give it 2 minutes to up to 20 minutes after the start of meal also. Approvals are all in place for 1 to 6 years. And in GDM, as I told you, you can use regular insulin, and other insulins are getting some approvals in the GDM space, but regular insulins are good enough for GDM. And premix, of course, you can use any of the combinations. Usually we start with 6-10 units, and usually you need to give it before meals. And of course, we have the co-formulations. Most of the co-formulations are not approved for pregnancy. And of course, we can have NPH, which is useful in pregnancy. The basal insulins can be used, but you have some cautions there when you use it in pregnancy. And usually the recommended dose is 10. So keep it simple, don't make it very complicated. And then when you want to titrate it, you need to do a lot of education. For example, we have to look at pre-meal values for a co-formulation. And if it is less than 80 minus 2, 80 to 130, 0, 131 to 160 plus 2, 161 to 180 plus 4, more than 180 plus 6. And if it's a bolus, then if the Prandtl is 140 to 180, no change. Above, but between 180 to 200, increase the dose by 2 units, 200 to 224 units, to more than 226 units. So consider the mean of the last 3 lowest values, and then appropriately adjust the dose. So a lot of patient education is needed. So clearly, insulin is an important step to initiate. And I would strongly recommend hit hard, hit early is what Dr. Virmani said very nicely. We start with lifestyle OADs, but you can always consider a basal or a premix insulin with OADs to initiate. And then you need to optimize by titrating the dose with maintaining glucose target, but also not causing hypoglycemia and weight gain. And sometimes you may need basal with 1 or 2 or 3 or 4 bolus insulins or premix with OADs to give an intensified for additional mealtime coverage. So it's initiation, optimization, and intensification. That's how insulin therapy is evolved. As I told you, for intensification, normally A1C target, within 0.5 unit per kg per day for basal insulin. If you can't achieve the target, and try to achieve a normal fasting with basal insulin, and then target, of course, the Prandtl glucose. So obviously, to intensify, you can have all permutations combinations. You can use basal plus, you can use basal bolus, you can use basal insulin with GLP-1, you can use once a day co-formulation, we can use thrice a day or twice a day premix regimens, or twice a day co-formulation regimens. So all types of permutation combinations are available now, and life has become more difficult for doctors at large because of the availability. Then dosing and switch is also a challenge, because nowadays we are getting new insulins. For example, how does one switch? If you have a IDEC Aspart or IDEC Lira, it's not easy to switch. There are switch regimens available for all manufacturers, but usually by and large, we need to understand that when you are using a premix, try to give 2/3 of the dose in the morning and 1/3 at night. Or you can split 50-50 equally at breakfast and dinner doses. And that's the time we sometimes use 50-50 also. It's a good insulin, particularly if you eat more carbohydrates. And in basal bolus, the 50-50 dose works very well. So, insulin, we can keep talking on it, and it's a long subject. It's available for more than 100 years. It's what our pancreas and our portal vein has to regulate our glucose. And, despite of whatever may happen in diabetes today, insulin will still remain. I have not talked of Icodec, which is a once a week insulin, which will be available by the end of the year or next year in India. I have not talked about inhaled insulins, which are also available, but have got extinct. And I've not talked about oral insulin because currently they are not available. And of course, insulin patches and oral insulin still look to be a distant possibility. So each regimen has its own advantages and disadvantages. But I think the basal insulins have made our life much, much easier. And basal plus, basal bolus, premix, and co-formulations, it allows us to give us a lot of other options for us. So I think I'll stop here because, I'm mindful of time. I was given a finite duration of time, and I'm certain that there'll be a lot of questions. I'll be happy to answer questions. Thank you so much, Dr. Parikh, for the kind opportunity.
Thank you. Yeah, thank you, Dr. Shashank Joshi. I think you have actually explained everything, nitty-gritties to the intricacies of the insulin management, insulin therapies. I think nothing more than anything required for the the management. Now we can start the question and answer, and now the first question by Dr. Kalra. He is asking which drug you will choose in the middle-aged people make having the fasting hyperglycemia with early postprandial hyperglycemia, but hypos at 2 hours. Very unique situation. Dr. Virmani, can you
Yeah.
answer this?
I think very interesting question. Now we have to look at what is happening in the biochemically. Patient has fasting hyperglycemia, I said. So that is because of the increase in the hepatic glucose output, because that is the predominant contributor to fasting hyperglycemia. Number two, there is early postprandial hyperglycemia. That is because the first phase secretion is gone, second phase is delayed, so the postprandial rises early. And there is a postprandial reactive hypoglycemia after 2 to 3 hours, because then the insulin starts increasing. So what is the best drugs to give? Best it will be a combination of metformin with the AGI. I think metformin will take care of hepatic glucose output, and the AGI will take care of the postprandial, so that there is no increase in the hypoglycemia after the postprandial is there. So the best combination will be that. Metformin, AGI.
Yeah.
If anybody has
SK Sharma sir, unmute yourself.
any
Uh,
question?
yeah, you are right. Little bit. Can you add something, because here the unique situation
Yeah.
is early postprandial rise and postprandial hypoglycemia.
Primary two drugs, but then you can always add an insulin sensitizer like pioglitazone,
Yeah.
which will yeah.
Yes.
There's no doubt about it. But the two primary drugs which are covering the basic pathophysiology here are metformin and AGI. Then, of course, you can add a pioglitazone if it is still not controlled, or you can still add a DPP-4 if it's still not controlled.
Okay.
So, but
okay.
I said to start with, let me start with these two drugs. Third drug will be my choice will be pioglitazone. Fourth will be DPP-4.
Okay. Okay. Dr. Sharma sir.
I think Dr. Virmani has given clear-cut answer that in this type of situation, AGIs, alpha glucosidase inhibitors are useful. And then, of course, DPP-4 inhibitors can be used. And you have to look at what times patient is developing hypo. And during that time, you can give a small snack so that he may not develop hypoglycemia also. Thank you.
Yeah, I think nothing better than the AGI in this situation. You are perfectly right. And the combination with metformin, or as Dr. Sharma said, DPP-4 inhibitors can be given in this situation. Now, another question by Dr. Neeraj. He is asking, which drug reduces the glycemic variability, and any consideration in selecting the drugs? Dr. Virmani?
Okay. Now, once we are talking about glycemic variability, first of all, we have to diagnose, because there are two contributors to glycemic variability. One is hypoglycemia on one side and excessive hyperglycemia on the other side. So we need a drug which balances both, controls hyperglycemia, does not cause hypoglycemia. So all the drugs that do not cause hypoglycemia can basically control glycemic variability. And if you need, then the only answer is get a CGM, know what time it is occurring. If it is hypoglycemia, cut down the risk, cut down the drug at that time. If it is hyperglycemia, add a small acting, short duration acting drug, or maybe even a prandial insulin. It depends. So it is going to depend. Basically, aim is to cut down on the excursions of hypo and hyperglycemia. There is no drug as such which you say that it will absolutely cure glycemic variability. You have to cut these two excursions. Am I right, Dr.
But there
Sharma?
are some evidences. Dr. Virmani, there are some evidences of DPP-4 inhibitors and the SGLT2 inhibitors.
There are evidences with dapagliflozin. There are evidences with DPP-4 inhibitors.
Empagliflozin also.
Because they don't cause hypoglycemia. That is why. See, what I'm going to the basic pathophysiology and then building on it. See, it is important to realize why I'm giving this drug. It's not giving blindly.
Okay.
So I must know my aim is to cut out hypoglycemic, excessive hypoglycemia as well as excessive hyperglycemia. So I need a drug which is good at lowering hyperglycemia but does not cause hyperglycemia. That drug will be excellent for glycemic variability.
Yeah. Dr. Shashank, can you little enlighten about this thing? The drug suitable for reducing the glycemic variability, Dr. Virmani has excellently explained.
I think I would echo what
Yes.
SK and Dr. Virmani said. Two things you need to recognize. One is, if you skip your meal, skip your drug. If you have half your meal, take half your drug. If you take your full meal, you have full dose. But the challenge is that many of the newer agents, okay, they technically don't so-called cause hypoglycemia. But even then we see that if we are having a very poor intake, they become frail and they have very low glucoses. That's number one. Number two is that, it depends on the meal pattern. So if you have 3 major meals and mid-meal snacks, or 2 major meals with mid-meal snacks, or just 2 large meals without any snacks, then obviously the glycemic excursions are a function of your physical activity and diet. Also, we have recognized that suppose somebody goes to a gym in the evening and causes a vigorous physical activity, he will get hypoglycemia at 12 o'clock or 1 o'clock at night.
Right.
If he's taking a medication even at night. So it's important that we understand the equation between the duration of the drug, the time action profile, and this thing. So what Dr. Virmani is saying is all the agents which don't cause hypoglycemia, naturally, they don't fit in this equation. So sulfonylureas were the only, or the glycides, they are the ones which fundamentally, or insulin, where hypoglycemia, you need to understand the physical activity and the food. Other drugs, they will have a better role on the glycemic variability. Unfortunately, even with the other drugs, if the food pattern is erratic and the carb loading is high, you are still going to get peak and valleys. What you are alluding to are those peak and valleys. And therefore, it's very, very important to recognize that even if you are using an SGLT2 inhibitor, a DPP4 agent, and or an agent which doesn't cause hypoglycemia, we need to be mindful of our eating habits, eating pattern, and physical activity pattern. Because and also remember, there are vulnerable groups, elderly population, because they have compromised GFR, particularly above 80, 90, or 100. And secondly, people who have renal compromise. So even the drugs who are so-called not going to cause hypoglycemia. But if you are looking at a senior citizen at 85 with a creatinine of 1.5 or 2 or a low eGFR at around 20 or 30, you will still get a peak and valley phenomenon, even if the drug is so-called having a better glycemic variability. But I think the newer agents clearly have an advantage, and there is no question asked. Also remember, some of the drugs cause nausea, whether it's metformin or whether it's the injectable GLP-1 agents, including oral and injectable. And when there is nausea also, the entire glycemic variability goes for a toss. So morning they have nausea, afternoon, they are still nauseated. At night, they will have a large meal. And, the whole glycemic variability goes for a toss. So you may think that these drugs have less glycemic variability, but now we can actually see everything. All of us have CGM. So we can actually visualize the highs and the lows.
Yeah. Thank you, Dr. Shashank. Another question by Dr. Kaushal, and I also add a little bit on that. Please, Dr. Pathak, please, can you mute? Yeah. Okay. So another question by Dr. V.N. Kaushal, and I also will add in this question. He is asking that can PIO be given to the patients who have macular burn or I think macular edema? Another question regarding the side effects profile. You have elegantly mentioned the side effect profile of the PIO. Can you, the newer agent like lobeglitazone can be given in place of pioglitazone? This is the question, Dr. Virmani.
First of all, you see, if you're talking about macular burns, they usually occur due to direct vision sunlight or by the laser treatment, YAG laser and all, or even the lasers that we use. It can cause macular burn. And the problem with that is it can lead to loss of central vision. There might be a little bit of macular edema. So definitely PIO is not indicated in this. As far as lobeglitazone is concerned, it's a new drug, data is limited, though it is mentioned that it has got lesser side effects than pioglitazone. But personally, I don't have any experience with this drug. And I think we need to wait for more data before we can put it at par with pioglitazone. Pioglitazone has got wonderful CV OT trials with in the proactive as well as the IRIS trial. Lobeglitazone doesn't have any data so far. So it is just a marketing strategy right now. They are bringing newer and newer, and they are telling us that this is better than the old drug. But I'm not going to accept it unless I get data.
Okay. Of late, I have started using lobeglitazone, having little bit, I mean,
at least that will create some data.
Good results, but I don't know, Dr. Sharma, Dr. S.K. Sharma sir, what is your experience
again,
with the new agent?
as Dr. Virmani highlighted, we have very little data and very little experience of this lobeglitazone. And of course, only thing is that it is to be used in a smaller doses rather than milligram wise. It is to be given in a low dose. Otherwise, we don't have, you can say, data to differentiate between these two. So still to wait and watch. Thank you.
Just one comment.
Okay.
Pioglitazone, our pharmacy student of Dr. Panikar and me, we published paper 7.5, 15 and 30. And we showed that 15 or 7.5 can cause the same degree of insulin resistance what 30 and 45 used. And the data on pioglitazone is very sound and robust. So I agree with Dr. Anil, what he's saying. The data is consistent. So my first choice is always to use a low dose pio. Okay. As a preferred, lobeglitazone is a good agent. I have used it also. Okay. And I have used it, anecdotally, they claim that it causes less edema. The dose to dose is, as Dr. S.K. Sharma said, is a little lesser. It's one more, agent of the clip. But I want to add one more agent, which is also available. And our liver doctors have gone crazy about it. It's called a saroglitazar. Okay. Now, what has happened is, whether you like it or not, saroglitazar is prescribed left, right, and center by all the liver specialists. I'm standing to be corrected. And I see that it is already there. And fatty liver, triglycerides are high because of uncontrolled diabetes. And person is already on 4 milligrams of saroglitazar. There, the glycemic control is pretty good because it has a alpha and a gamma action both. So you do get a sensitizing potential from saroglitazar also. Again, the evidence base is restricted to India. We have now more than 6 years of experience. I use saroglitazar even in infertile women with PCOD in rare cases, and we have got fertility coming out. So remember that it is not just pio, but pio-like agents like lobe and saro are available in India. Patients will come. See, we are tertiary care doctors now, so patients will already get the agent from somebody else. So am I going to stop and move them to pio? Probably not, because the action of efficacy is almost similar. Safety, we don't know. Long-term outcome data doesn't exist. And the last comment is about if somebody has a macular edema, okay, not macular burns, macular edema, I will take away the patient from pio. I'm very clear. I have better other agents where I can use. If I really want insulin sensitization, occasionally I have even used, but I can't use hydroxychloroquine. But other agents I can try, including metformin. But if there's a macular edema documented, then I will not continue pio. That's a given, because it's a known documented side effect. And it is not that we have not seen it. So as much as we have seen, the only advantage now we have, what we didn't have 20 years back, is with pio, we have a DAPA to use, or a glyphosine to use, or a AGL2 inhibitor to use. So I feel that they sort of synergize each other and counter each other's effects, and they give us the best of both, insulin resistance as well as SGLT2 ka cardiorenal protection. So, and I think Anil put it very nicely in his slides. I congratulate you for all your wonderful slides. I know you tried to compress everything in a long duration.
Absolutely. Yeah. Dr. Shashank, I have one question regarding the approval of degludec in pregnancy in GDM. Can we use degludec in pregnancy?
Degludec are not contraindicated in pregnancy. But my first choice is to still use NPH and regular insulin. Okay. See, I'm very clear that safety is always first. And in pregnancy, it is all about MNT. But in pregnancy, the tight glycemic control matters. And using
what about in infants? Yeah.
Even in infants, as I said, regular insulin works very well. Only challenge with regular insulin is hypoglycemia, and you need to know the time action profile better. So my personal preference is still regular.
And Dr. Virmani asked,
I do use analogs in pregnancy, but my first choice in pregnancy for a basal insulin is still NPH. I'm very clear about it. In the bolus category, however, I can use a analog because that data is much more robust.
Okay. This is regarding Dr. Virmani's questions. He is asking that what is the over insulinization with degludec?
Stacking.
Do we?
Long half-life.
Long half-life, but stacking is not something which we know now pharmacologically it doesn't cause any stacking. So really that's not a major concern for us.
Yeah. Dr. Pradyuman Sharma sir, I think without your questions, I don't.
Without his,
I have one point. Oh no, thank you. It was very excellent, and to listen to two great legends. Really, I'm very much enlightened. Dr. Virmani, how would you address sotagliflozin, which is a primarily SGLT2 and SGLT1 inhibitor? Out of, if you have a choice with the empagliflozin and sotagliflozin, and especially in patients with heart failure. So how will you address this molecule?
Right. Sotagliflozin is a dual SGLT2 and SGLT1 inhibitor. It has shown very good results in the CVOTs, and it appeared to be much better. But unfortunately, because of some technical problems, this was not, the marketing was not done properly. The production was stopped. So I doubt whether it's going to be available in India at any time. But definitely, there is no doubt we had very good data with sotagliflozin.
Also with heart failure.
Yeah, also in heart failure.
Especially in heart failure.
I think the scope of this session was the oral hypoglycemics and the insulin, but Dr. Saket Bhandari is asking regarding the reversibility of the type 2 diabetes with lifestyle changes. I think very briefly, Dr. Sharma or anybody, Dr. Shashank can ask because it needs a great session itself. Though the scope is not there, I think we have to answer.
I'll be very quick. If you are type 2 diabetes with adequate beta cells in the first decade and younger patients, shorter the duration, younger the patient, and type 2 diabetes, particularly obese. And if you do caloric restriction to 600 to 800 calories per day, you can in 50% get diabetes remission. Okay. The drop trial, which is done in Jocelyn, if the diabetes duration is less than 2 years, and you follow 8-16 intermittent fasting with only 800 calories, you can get almost 100% remission. If you go through any of the apps with CGM, you can get up to 75% remission. But remission is possible. Sort of cases is possible. But let's stop there because it's a big subject by itself. It's a separate topic.
In this session, we have Professor A.K. Gupta Sahab, Dr. M.M. Singh Sahab, and so many people are here. If they want to have any comments or any questions, all are welcome here. Otherwise, we'll take the permission and final comments from Dr. Parikh sir.
I first of all wish to congratulate Dr. Anil Virmani for an excellent lecture on oral hypoglycemics and their wide approach, how to approach a patient and how to treat. It is an excellent presentation. The second thing which I wish to convey, Anil Virmani has asked me personally if I was in Medical College Meerut. Yes, I was there in 1973 and 74, and I was lecturer in medicine. Maybe you are talking of 1971. Maybe you might have attended one of my lectures there.
Yes, sir.
So
I have attended, sir. I am your student.
Yeah. So it's very nice that one of my students is talking so brilliantly in a national conference like Indian Association of Clinical Medicine. So I congratulate you once again.
Thank you.
As regards Dr. Joshi is very emphatically and very in clear words emphasized the importance and use of insulin in the various daily practice, and I think it should be helpful to all the persons who attended. And I must also congratulate Dr. K.K. Parikh that it is one of the, I say, one of the two best CMEs, where attendance till the last has been almost 90%. And the topic of daily one-to-day, let's say day-to-day practice, and such sessions are recommended in the future also for the better public advantage. Thank you, Dr. Parekh. And Dr.
Sir, it is almost 2 hours, and still the people are here. I think the great applause goes to all the legends here, Dr. Shashank Joshi, Dr. Virmani, Dr. Sharma, and sir, final comment from Dr. Parekh, sir, before we wind. And I think this is something very unusual thing I see in 2 hours. Thank you very much, most of the,
Just a minute, sir. I am Dr.
all the delegates.
Just a minute. Just I want to ask one question.
Yes, sir. Yes, sir.
Many patients of diabetes, they have very high fasting blood sugar, but PP blood sugar decreases by 30 milligrams, 40 milligrams, even without any drugs. So how to tackle with those patients of diabetes?
When you eat very fast, your PP tends to be low. So the first thing you should tell them is eat slowly. If they are eating slowly and still the PP is low, then you need to modify the medication, whether it's insulin or tablets. But what I have seen very commonly in clinical practice is, if the fasting is high and PP is low, these patients tend to eat very fast. They clear their plate in 5 to 10 minutes. And minute you tell them to eat slowly, you can see the prandial glucose excursion happens. Otherwise, the medication given around that particular meal or before that meal needs to be modified, or dose needs to be downregulated.
Okay, thank you.
Another comment, Dr. Nirmal.
Yes.
If you see a patient with isolated fasting hyperglycemia for the first time, newly diagnosed, you have to rule out glucokinase mutation. If this due to glucokinase mutation, you don't need any treatment. If there are any other comorbidities or other target organ effects, then you need to treat the fasting hyperglycemia with sulfonylurea given in the evening.
Good evening, sir. May I just...
Is a good blood for fasting hyperglycemia.
Good evening, sir. This is Dr. Colonel S.K. Singh, sir. I am Professor of Medicine, FMC. And just a small comment about this session. It was an excellent deliberation by two stalwarts. And many of my residents, even sitting in the ward, doing their ward duties, sir, they have been benefited. This is a feedback from all my residents. It was a great session, sir. And we are looking forward to have a similar sort of session where all my PGs will be benefited. Thank you very much, Dr. Virmani, sir, and Shashank Joshi, sir, and all the organizer of IACM.
Thank you, Dr. Singh. I think this is something very good comments. And Dr. Parekh, sir.
Yes, thank you. Thank you, both the speakers, great stalwarts of medical fraternity. I mean, they done an excellent job, excellent deliberation, and with good interaction. I mean, everything has been cleared. These topics are so big that they have covered in a very short time and taking everything. Nothing has been left, whether it is oral hypoglycemic agents or insulin. So thank you very much, Dr. Shashank and Dr. Virmani, for being here. We are really grateful to you, given very less time for lecture. Thank you again to grace this opportunity. Just a minute, please. Just a minute, please. And I also extend my sincere thanks to the chairpersons, Dr. Puneet Saxena and Dr. Pradeep Sharma. So nicely chaired these sessions, and extend thanks to Dr. Arvind Gupta, so nicely moderated and asked the questions and their answers, and so nicely interaction. I mean, it was a really to see a great interaction between the delegates and the speakers and the other endocrinologists. So thank you very much, and thanks to everyone, delegates, to make this CME successful. Just because of you, your attendance made it a great success. Thank you, everyone, and thank you so much, everyone, and Dr. S.K. Sharma as a guest of honor. Thank you so much, sir, for to be here and grace the occasion. So it had been a wonderful CME program, great awareness among the clinicians. I think these type of CMEs, online CMEs, are also very, very important. Although physical CMEs are important, but I think the more important for dissemination of knowledge as the online CME. I mean, we had such a good discussion for 2 hours, more than 2 hours. It's really great. Thank you very much, all of you. Yes.
Dr. MP
Everybody
Singh.
is asking.
Good night, sir.
Dr. MP Singh,
To all
sir,
the dignitaries.
I think now session is yours.
It is commonly said, and quite correctly so, better than 100 hours of diligent study is 1 day spent with a great teacher. And we had such great teachers with us. I studied, last time I studied oral hypoglycemic agents and insulin was when I was doing my MD. Ever since I've done my DM, I've never studied them. But it was such an eye-opener. It has progressed so much. And it was an absolute delight to have Dr. Virmani and Dr. Shashank Joshi speaking for association. Thank you so much, sir. I would now request Dr. Puneet Saxena, sir, to say a few words. We did not give him the opportunity to, really put his thoughts to the association.
Thank you so much,
Yes.
Dr. M.K. Singh, and thank you for having such a nice online series by IACM where we have such luminaries who are speaking, and I've been attending these. Thanks, Dr. Parikh Saab, Dr. M.M. Singh Saab, and all the senior persons, and thanks to the speakers who have done justice to the topic given, and I kept the interaction live for almost 2 hours, and so nice moderation by Arvind Gupta ji and S.K. Sharma ji, and my senior colleague, Dr. Pradyuman Sharma from Jaipur. So with that, bidding goodbye to and good night to everybody and happy Janmashtami. Thank you very much.
Thank you, everyone.
Happy Janmashtami to all.
Thank you.
Thank you, everyone. It was a pleasure to have you with us. Please join us for
Good
all
night.
future
Good night,
meetings.
everybody. Good
Good
night.
night, everyone.
Thank you. Good night.